Good afternoon and welcome to this session. My name is Chandramouli and I work for the World Health Organization and I lead WHO's work on adolescent sexual and reproductive health. So welcome to this session on designing an emergency response with the adolescent girl in mind. What I'm going to do is give you a little bit of background as to the rationale for the session, and then introduce the panel, and then let the panel get on with the task of discussing the issues and engaging you. And then I'm going to try to come back in the end and try to pull some of the threads of the discussion together. We're talking about an emergency response, and we're talking about dealing with the sexual and reproductive health needs, but the other needs as well of girls in that situation. But before we do that, it's useful to talk about what's the baseline. What's the situation of adolescent girls in peacetime? Most girls know less than boys about sexual and reproductive health. Many girls around the world learn about their periods on the day their periods start. And if girls ask questions of their parents or teachers, they said, good girls don't ask such questions. When a young married woman in many places goes to a health worker and asks for contraception, she's asked to come back after she's had a child. Health workers tell them that, contraception could contribute to your infertility. Go and have a child, have a male child, and come back and we can talk about contraception then. For unmarried girls, generally don't go to health facilities for contraception. They might go to a pharmacy, and a pharmacist may give the contraceptives, generally emergency contraception, to them, looking at them with disgust. That's the response you hear in Ethiopia, in Malawi, in India, and around the world. Young woman comes with signs of gonorrhea or a sexually transmitted infection. I've been in clinics where nurses have said, you prostitute, you're stealing our men. There have been papers published about girls with incomplete abortion coming to clinics and health workers telling them, you've had sex, you've terminated your pregnancy, now you stay for an hour and suffer. As punishment for having, first of all, the pregnancy, and secondly, the incomplete abortion. So that's the reality in peacetime, if you like. It's a war in the peacetime. And in a humanitarian response, in a humanitarian situation, it gets a lot worse. So let me give you some illustrative examples. Nepal, there's a huge earthquake. And before the humanitarian responders land up, the human traffickers are already there. The human traffickers are there to grab the girls and take them away. We've all watched on television, and some of us have been there on the ground to see the huge flood of people escaping brutal violence in Myanmar and South Sudan. And in Syria, over the last 5 years, bleeding of the population into Lebanon, into Turkey, and then elsewhere in the world. What you have in the Democratic Republic of Congo is two terrible crises at the same time in a country which is already down on its knees. Ebola on the one hand, and an armed conflict on the other hand. Our Director General, Tedros, has been there over 10 times, trying to resolve peace, trying to strengthen the Ebola response, which seems impossible to do with these two problems together. And then the tragedy of Yemen. Already a poor country with weak infrastructure, slowly ongoing destruction and famine. Now, these kinds of situations affects everyone. It affects everyone who's involved. Children die, women die at childbirth, people who are on medication for blood pressure or high blood pressure or a kidney ailment or cancer treatment cannot have access to this care. We hear these reports in Venezuela, for instance. But adolescents, adolescent boys, adolescent girls are vulnerable too. They're vulnerable because the protective systems in the family, in the community disappear. And in terms of sexual and reproductive health, an already bad situation becomes much worse. Like in the Millennium Development Goal period, the 2000 to 2015, when adolescents were largely neglected, in humanitarian emergency situations, the needs of adolescents are generally not taken into account. And sometimes an adolescent blind response, a well-intentioned adolescent blind response, can actually put in place systems which actually affect adolescents badly. For instance, setting up toilets in a place which are a further distance from the camp without lighting can actually increase the vulnerability of girls and women. That's the kind of discussions we want to have here. A lot needs to be done, but in this context of crisis and chaos and shortage of resources and lots of humanitarian workers coming from different parts of the world with different languages and sometimes very inappropriate responses, how do you make sure that the adolescent girl is first not forgotten and responses that are put in place are appropriate? So to lead the discussion, we have Khadija Moore from the Dominica Planned Parenthood Association. A wave. We have Julian Deitch from the Women's Refugee Commission, Amani Kanjo from the Syria Relief and Development Association, Ablima Jesmin from UNFPA, Muzna Dureid from the White Helmets. I'm one of the great fans of your work and looking at what you'll have done in Netflix. A real great work, all of you. And Zainab Sherry from Women Delivers Humanitarian Advisory Committee. So over to you. We look forward to a lively discussion. Thank you.
Good afternoon, everyone. I am Khadija Moore, and thank you for tuning in to my show, What We Want. To those of you joining us live in studio, we would like to thank you for being here. And those of you watching live, I would like to say a special welcome to you all. As you know, we talk every day about what adolescent girls face, what they struggle, what they face in humanitarian crisis. And today we are going to discuss what they want to do and what they can do. Who here identifies as a young person? Please raise your hand.
Physically or mentally?
Physically, please. And who here identifies as an adolescent? Can someone please tell me what an adolescent is? Okay. Well, the difference between a young person and an adolescent is a young person is between the ages of 10 to 24, and an adolescent is between the ages of 10 to 19. Today, we are going to talk about girls in humanitarian settings. These are girls and young women who, like myself, have experienced a natural or man-made disaster that have basically disrupted their normal lifestyles, and they watch as their everyday routines and their sense of security are disrupted. Within the space of 2 years, my country was devastated, first by a tropical storm. It was called Erica, and a major Category 5 Hurricane Maria. I watched as many of these young people were left basically displaced and unsure of how to cope with their new circumstances and the new realities that they faced. Going to school, playing sports with friends, even seeking basic medical attention at a health facility, they were no longer guaranteed. What if that girl gets pregnant? What if she needs a contraceptive? What if these young people are looking for services, who do they turn to? What help are they going to seek? Today, we will be speaking about all of these and more. I have brought 4 staff to speak with you today, and these hashtag humanitarians for her will have to answer questions from the audience. And today, as a special treat, I have also flown in several young people from a humanitarian disaster to join our audience. I don't need to tell the crowd that adolescents matter. We all know that some people still do not understand the challenges that young people face, adolescents in particular. So today, we are going to see how best we can challenge the problems that we face, and we are going to see how best we can move forward from that. Who here has lived or worked in a humanitarian setting?
I did. My name is Zainab Shirri, and I am from Lebanon. I worked with the International Medical Corps on an assessment of sexual and reproductive health of Syrian refugee women of reproductive age. This assessment aimed at assessing the sexual and reproductive health needs of these women in order, with a focus on early marriage perceptions and behavior, in order to improve the services provided and their acceptability. I also worked with the American University of Beirut in partnership with CARE Lebanon on a project with adolescent Syrian refugee and Lebanese girls living in Tripoli, which is considered one of the poorest cities on the Mediterranean. The project aimed at decreasing the girls' high school dropout rate to protect them from early marriage. Some Syrian adolescent refugee girls in Lebanon are trapped in a vicious cycle. They are subjected to early marriage, so they end up dropping out of school. Others drop out of school because of challenges, and they end up getting married. As such, they are at risk of health. As such, they suffer from, if they get pregnant, they suffer from health risks during and after pregnancy. So the girls are trapped out of school, and there are reasons behind that. They face challenges. Other than being subjected to discrimination, they face difficulties learning the Lebanese curriculum, mainly because of language barriers. In Syria, the curriculum is taught in Arabic, while in Lebanon, math and sciences are taught in English. So, as a result, the girls drop out of school. Other than that, high schools require official registration papers, and some of the girls are not registered, so they cannot be in school.
Thank you, Zainab. And though the challenges that you've seen are different from what I've seen, we are very similar because we both experienced and saw other young people putting themselves at risk to get basic items such as food and water. We have also seen how hard it is for these girls to get information, services, and supplies related to their sexual and reproductive health and needs. Who wants to talk about that? Not even the parents. So Zainab, why should we talk about adolescent girls in humanitarian settings?
So, 1 in 10 registered Syrian refugee in Lebanon is an adolescent girl. But there are many who are not registered, so the numbers are bigger. Unpublished data show that up to 25% of Syrian adolescent girls in Lebanon are prone to early marriage. Since they drop out of school, they become financially dependent on their husbands. They are deprived of their childhood, and they are deprived of reaching their potential as doctors, women in STEM sciences, social scientists, pilots, etc. They are also at risk of domestic violence and emotional distress. If they get pregnant, girls and their newborns face health risks. In addition to that, they face a lot of mental issues and health problems. So, should I say more? Yesterday, someone asked me why sexual and reproductive health services should be prioritized when basic needs are not met. Well, sexual and reproductive health services for adolescent girls is not a basic need. It is an essential right. Why should we just focus on providing them with basic needs when we could empower them to determine their own needs? Let's build back better. Let's make them superheroines.
Well, Zainab, I could not have said it better myself. We do have to provide avenues for young people to get the information that they need. And of course, there are many obstacles, but we would like to know what the main obstacles to adolescent receiving SRH is. So, Musna, can you please tell us more about that?
The challenge is access in Syria mainly because we have 31 women's centers inside Syria for the White Helmets, and we providing maternity health services for them. But the dangers of to having access to those centers, it's the most difficult thing because the health facilities, they are the first target of bombardment by Assad regime and the Russian army. And for the White Helmets especially, there's we're suffering from double attack, which is mean the first attack happening for civilians. And when our team came to the scene, so the second attack happened. So this is why women be afraid of coming to the facility centers, to the White Helmet centers, because it's too dangerous, and they know like each second there's like a real threat on their life.
Okay. Who in this room has had difficulty accessing these services, such as trying to get contraceptives, including condoms, or get information on basic changes in their bodies? Thank you. Musna, can you please tell us about this?
Actually, as Zainab said and mentioned, it's too hard to asking women under bombardment, like to giving them condoms or like contraceptions, and their life and under threat. So what we're working on the White Helmet, we're saving lives from under rubbles, and taking them from under rubbles to our centers and to the hospitals, and after we providing another materials and services for them. So we should like balance between people on conflict zone, that their life matters, and after they need those in parallel time, we should not took away about like their life. And we should also mention what's the problems in what's the roots or of these problems in those areas. And also to mention that just as example, in Syria, the Syrian humanitarian workers and the Syrian humanitarian organization, they carry out 75 of medical needs in Syria. Yet they receive 0.3 of Syrian aid budget, only 0.3. So, and this is explained that we have on the White Helmets 3,800 volunteers, and their monthly their monthly salary is just like $200 in the most dangerous area and the most dangerous kind of work. So this is like explain why we accept whatever the circumstances it's in Syria, because we belonging to the cause, and we belonging to the people. Because we are local, and we're serving our people, and we wanna like saving lives before and after to giving those services for women, because we couldn't ask them to follow the reproductive health rules without saving lives.
Your work in Syria is very promising, and it's very inspiring to learn about how programmers are taking creative approaches to tackle such issues on access. As it is research-based, maybe you can tell us what WRC have found helps increase access to SRH services for adolescents. Julian, can you please take the mic?
Thank you so much, Khadija. Thank you, Ms. so much for sharing that. Her story really highlights how there are sometimes extreme physical barriers for girls to access reproductive health information or services. But even in settings where there aren't these very complex physical dangers in accessing services, we still see that adolescent girls may have difficulty to reach the right kind of information and the right services. WRC is currently working on a project with UNICEF that's looking at innovative ways of reaching adolescent girls with critical SRH information and services. And actually in Lebanon and Iraq, we have also found that Syrian adolescent girls might have trouble to access a physical space where they can get this information. A promising approach has been to provide information and services in safe spaces for women and girls. Safe spaces for women and girls are quite effective in offering multiple services, a range of services really that respond to the needs of adolescent girls. This includes livelihood activities, GBV prevention and response, mental health, psychosocial support, life skills, as well as SRH information and services. Despite their successes, however, we know that these safe spaces are only reaching a very small percentage of girls. Not only do girls have barriers accessing, but they also might feel too shy or too embarrassed once they reach the physical space to talk about sensitive issues related to their sexual and reproductive health. Also, there are certain girls who might be even more marginalized or excluded, such as girls with disabilities or girls who are out of school, and as well as married adolescents who might be less likely to reach the physical safe space. So WRC and UNICEF, we're about to launch what we're calling a virtual safe space. This is a web-based platform where girls can access age-appropriate and factual information on SRH that they might otherwise get in a physical safe space. And this is based on our field assessments that showed that girls are really thirsty for more knowledge, and they do use the internet to try and access information, but oftentimes they can't find the right information, or it's not adolescent friendly, it's not in Arabic, or they might find information that's not appropriate or factual. So we're designing this virtual safe space for them to be able to have a reliable source of information that they can access on their mobile phones. We're going to be piloting the app later this year in Lebanon and Lebanon and Iraq with Syrian adolescents. And then hopefully, based on the piloting, we can expand the app and have it be more widespread for adolescent girls everywhere.
Virtual safe spaces, that is such an innovative idea. I really do see this trending in the future. If you had to speak of one theme that is consistent with this project, what would it be?
I would say what's really important for us is to really meaningfully engage adolescent girls in the entire process of program design and implementation, as well as monitoring and evaluating the effects of our programs. Meaningful engagement means that we really understand what are the true needs and priorities of adolescent girls. And this starts by conducting research that helps for us to understand what their needs are. You'll see a picture here of an activity that we actually did with adolescent girls. I believe this is from Lebanon. You can imagine when you ask girls what their needs are when it comes to sexual and reproductive health, they might not feel totally comfortable to talk about this sensitive information, and they might not be able to fully articulate what their needs are, especially if they don't know that services could be available for them. So how can they say what they need if they don't know that that service is available? And an approach that we've used that's been pretty popular and successful is this body mapping activity. And a local researcher will sit with the girls and ask them to draw 3 pictures, one of a very young girl who's 7 or 8 years old, then one of an adolescent girl, and one of an adult woman. And she'll guide them to really highlight what changes, physical, emotional, and social changes that girls go through from the time that they're a child to the time that they're an adult. And this really helps girls to feel a bit more comfortable as they're drawing, as they're sitting in small groups and the facilitator goes around to them and asks them to describe their drawings. It helps for them to articulate the challenges that they're facing. And then they can really discuss in further detail what kind of services and programming they would need to overcome these challenges. And this is the same way that we came up with the idea of the virtual safe space, in that girls also describe that they, use the internet to find information and they can't find the right information, and through other activities that we did, such as storytelling and role playing, girls were describing mobile devices as a really central way for them to get information. So yeah, and this approach also kind of sets the tone for girls to be more actively involved in program design as well as monitoring and evaluation.
And this is exactly what we have been looking forward to. And from my experience, I believe that while we urge and encourage meaningful youth engagement, and while some organizations have been pushing for it, there's still a lot more to do, as many organizations have not implemented that. And although we advocate for the inclusion of adolescent girls in all aspects of society, we realized that there was a major problem after these hurricanes, because even after the country was devastated by 2 major natural disasters, we saw that there was really a major need for young women to participate, girls to be active, and for them to be included in all that the government made, like all the decisions the government made and stuff like that. Also, Amani, you are working in the Syria context. Mazna mentioned how the attitudes of service providers can impact how adolescents react and how they receive SRH services. So can you please tell us more about that?
Yes, exactly. As you might know that since the beginning of Syria crisis, that the early marriage has significantly increased, and therefore the early pregnancy adolescent also on the rise as well. We know from speaking to adolescent girls that they are strongly demanding long-acting contraceptives. However, health providers not only treating those adolescent girls as unknowledgeable girls with little dignity, but also they are also telling them that you don't need long-acting contraceptives. You're still young. You can have more children. You got married early. And this is exactly what Dr. Chandler has highlighted before, that the issue is the attitude of health providers, the attitude of community members, parents, mothers-in-law, all think that larger families are can prove that the men that the masculinity of men is really great if he has like too many children in his house. This is the issue, and those children might raise up and protect each other during war and during emergency. So unfortunately, the attitude of the health providers, community members, significantly affect the Syrian adolescent girls' uptake of services.
Can you provide one example of how community attitudes have affected adolescent girls' uptake of services?
Exactly. This is what I have mentioned. Like also the mothers, the parents, really affecting what she wants. When she wants to have a child, what is the time, the right time? When she's got married, so she has to stop the school, drop out of school, as just Zainab has mentioned, and she has to directly have the baby as soon as possible, even if she's like under 18. This is the most highlighted issue has shown.
So what do you believe we can do to provide responsive services according to what adolescents want and what they need?
Exactly. What we are trying to do is like to integrate more programs for those adolescent girls, and not only dealing with adolescent girls, but also the social and gender norms of the health providers, of the community members, creating more committees for them, for the community to be buy-in, and more committees for the adolescents themselves to start to break out such a work inside their communities and to tell about what is the essential information, what is the rights, what when they have to have a children, what you can use family planning. You have to go for at least 4 times before having children.
Great. Amani has mentioned how service provider attitudes, cultural norms, and community perceptions and beliefs can help adolescent SRH or hurt the programs actually delivering services to adolescents. What other gatekeepers or people that can open and close doors for adolescent SRH are there in emergency settings? Can someone please contribute 1 or 2 responses? I believe so. Gatekeepers, they are not people who open and close doors, but they are partners who are increasing SRH services for adolescents. So Jasmine, you can relate to the idea of partnership. You have had to work with the people in several agencies outside of your agency, UNFPA. Why is partnership so important in this regard?
Thanks, Khadija. Yeah, of course, you are exactly pointed out, because it's not only the responsibility of the community, parents, and other people, but also the humanitarian actors. They really have a very strong role to really reach the goal of adolescent responsive health system. But really, to understand that things, we really have to understand the context for what I'm talking. Why partnership things we are emphasizing in today's discussion. So we really need to see where we work and based on what context we are talking today. So can somebody put the picture of Rohingya camps? Sorry. Okay. Yes, this is the place where we work. This is the biggest Rohingya refugee camp in this world now, where the world's most persecuted ethnic minority Rohingya population live. And 80% of the population here constitutes women and girls and children. So you can easily understand that 1/3 of the population are adolescent. So they are huge in number, but they are out of service. They need a lot of support, attention, and care, but it's very hard. You even can't imagine that how many people can live under one small hut. It's 5, 6, actually it's even more, like more than 8 people live in one hut. It's unimaginable, and it's very hot. So first time when I went to the camp, I felt like, oh my God, it looks like a Stockholm city, because all the roofs are kind of red color. In some places it's blue. It has faded away, but it looks like, wow, it's so beautiful. But after 2 hours, it's so sunny, so hot, it was very hard to stay there. But I don't know how 8 people live in one place. So you can imagine the kind of life there under the very conservative social conditions. And this is the camp condition. Globally, reproductive age is 15 to 49 years, but we work for the people in a community where reproductive age starts from 13 years. So a girl can even be pregnant at 13 years. We found this kind of case. So you can really connect Amani's context about community and parents level difficulties, but you can also see the kind of role as humanitarian actors we are doing. So after joining in ASRH, actually I worked for a long time on gender and GVV. So my mentor is already here, Dr. Satya. Many people know him maybe. So he really told and advised me, you'll be really good, Jasmine, in ASR-HR. And I was really excited to work on ASR-HR. So first day when I went to ASR-H subsector, and I found that nobody really talks on adolescent sexual and reproductive health. And I was not really happy on that day. And I was feeling, oh my God, how my mentor advised me to work on ASR-HR when even nobody talks. There are a lot of themes to work on ASR-HR, on SRA's sectors. Why in ASR-HR? I was really not happy that day, sir. But I was so frustrated first few days because We are talking unmet need is very high among adolescent girls. We are talking TFR is not reducing among the adolescent girls, but we are not really taking actions, as if we are waiting like the Rohingya parents that when this girl will be pregnant, when they will come to the facility, we are health provider, we are humanitarian actors setting up the health facility. We have a lot of service providers will deliver them in the facility, and they will have healthy baby and safe maternity. But we are not looking at the preventive parts and empowering girls so that they don't become pregnant early. So this was the context I really worked. However, there was really a nice platform we got, okay, even though I was frustrated in the beginning, but later, one word, what Dr. Satya always told me that patience pays. So I would say that in the October maybe, in the mid of October, so Interagency working group came with the training on, especially TOT on ASRH in crisis, and they trained 16 people. And trust me, after 16, during the training, it seems that everybody will work for ASRHR. But in 1 month, we found that it's hardly 5 people are really motivated to work for ASRHR. So we started, we did not stop. Everybody wanted no task force. Why another agency? We have a lot of task force. We have a lot of agencies. We have big health sector. We have youth working group, blah, 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 a lot of things. We do not need task force. But we didn't stop. So what we planned that, okay, we have to sensitize our colleagues. We have to sensitize our supervisor. So we started like this. We were 5 persons first targeted to transform ourselves as 5 agencies. So we had to motivate our colleagues, our team leads, and everyone. So we realized that our agency is really supporting us. After that, the magic happens. Even in the super dark, if you find a small dot of light, you can really make a shiny world. And that happened when we persistently trying to motivate SRS coordinator to be part of us, to understand the same way we understand. And finally, since January 2019, we'll say that, yes, it came. Patience really pays. And he's now really one of the, how to say, kind of very active role player for adolescent agenda to move on. And now it seems that this is the goal of SRS subsector. And we, SRS task force, has been playing a kind of technical advising group for him. So can you believe it was 5 agencies? Now SRS coordinator means representative of 50 organizations. So if the task force you consider as one single drop of water, when the drop of water falls in the sea, the drop of water doesn't become any more a drop. It becomes a sea. So now the task force you can consider is big part of almost 150 health partners now. So now we are working for 150 health partners. Even though we are in the momentum moment, it's still not very strong, but we didn't stop. We are still going ahead. So we have recently trained 15 senior managers, program coordinator, with the support of SRS staff sector. And we have planned that by this year, we will create 100 ASRA champions across the sectors, because people think that those who does SRA things, they are really very good on adolescent things. They understand. Actually, they are competent as health providers, as service providers, as RH managers, but they are not competent adolescent-specific program manager, adolescent-specific health providers. It requires special quality. And in the training, we found even the doctors, everyone failed. Maximum score achieved 26% out of 100, and it was the case. Actually, we really need adolescent competent workforce, and that is only possible if all the partners take some responsibilities. And I believe that now we can do, because we have now SRA subsector coordinator and health sector coordinator on board, and we'll move, we believe, yeah.
Okay. So now that the task force has been created, are you all set to roll out your ASRH programming?
Okay, it's very hard actually to say yes or no. We are evolving, we are growing, we are doing a lot of things. Many organizations are also doing a lot of things. But you know, the subsector, health sector, we have a dream of making adolescent responsive health system. But it's a big vision. And even though subsector coordinator is the representative of 50 organizations minimum, but he needs to transform this vision in every agency he represents. It is not an easy task. And therefore, he needs to fight internally, externally as well, because the donors, for example, they also behave like the Rohingya adolescent girls' parents. How? Because they also wait, they also, how to say, allocate their fund when the girl will be pregnant, when they will come to health facility, because they allocate funding for health provider salary, they allocate funding for medicine, commodity, and health structure maybe. But they really don't think one step before so that girls do not become pregnant before 19 years. She gets opportunity to learn, to learn, to explore herself, to understand how she can lead her own life and get autonomy over her reproductive health. Actually, we humanitarian actors have a great role. And in this case, we all have to support, even though internally we had a lot of fightings in the beginning, and still at the level of Cox's Bazar, but it should not be at the level of Cox's Bazar. We need to move beyond. And I will say the donor community, humanitarian actors, everyone has really, really big role, and they have to set indicators. We want to see no girls come before 19 years being pregnant to your facility. When the day you can do this, only then we believe that you are serving, otherwise not. Donors should think in this way. And this is the really important message that I want to give to humanitarian world from the point of view of task force and SRA subsector. Thank you.
Thank you very much, Jasmine. And I knew people loved this show, but I heard over the last commercial break that the group has been live tweeting about our show today, and they are called the Interagency Working Group on Reproductive Health in Crises. They call themselves IWAG. Anyway, it is really good to hear that humanitarians and policymakers are talking about ASRH and what more that we could do to close the gap on SRH service provision. Before we close today, I would like to give the floor to Zainab. She's a young woman who kindly shared her experience from Lebanon. Zainab, you reminded us all of the tremendous capacity of adolescents and young people to affect change from wherever they work. And what are you doing for your organizations and the activities that our guests describe by using young people as assets and using their collective power to advocate for their SRH needs and rights? I know it's a difficult question, but if you had to choose just one ingredient for a successful ASRH program, what would it be in your context?
Not only adolescents and young people are ambitious, have a lot of skills, but they are also sincere and dedicated. A major theme has been emphasized during this conference, and I don't think there would be any better ingredient. Simply, don't do anything for them without them.
Thank you, Zainab. When encouraged, adolescents have the potential to alter the status quo, change negative social ills, and chart a more promising future for themselves. My key ingredient would be to engage the youth directly. I believe by ensuring access to comprehensive sexuality education, education on menstrual hygiene, management, and communication among generations are pivotal in shaping the young people's lives and shaping for a more positive future. This is all the time that we have for today. I would like to thank all of my guests again for joining, and for my live participants. We will see you all tomorrow when we talk about how hard adulting can be when you are through with college. Thank you.
Hi, everyone. So you've heard the panel speak to a range of issues. Muzna talked about how difficult it can be, even for an organization providing relief and development services to provide sexual and reproductive health services, and how dangerous it can be for girls and women, and men as well, to come and seek care. Amani talked about community resistance, conservative attitudes, health worker bias. And she said, like in many places in crisis, families want to have more children because they see that the children are the only people who can help them survive this crisis. Julian talked about safe spaces and how mechanisms like that can be actually useful, but she also pointed to the fact that it's actually reaching very small numbers of girls and women. And then we had Aklima saying, in the context of this huge flood of refugees in Bangladesh, how do you get partners involved? What kind of systems can you put in place with very weak foundations? We have about 10, 12 minutes. Any reactions, any experiences that people would like to share? Any questions for the panel? Any suggestions? Yeah, please, Masa. And then I'm going to ask Lulu, my colleague in WHO, to talk about a study that she's involved in working with sexual and reproductive health in humanitarian emergencies. Go ahead.
Thank you. Hi, my name is Masa. I'm from Syria. First, I want to thank you all for the amazing, beautiful, inspiring work that you do. It's really tangible change that you're inspiring the world, so thank you so much. First question is for you. The application that you're piloting between Lebanon and Iraq, since it's a virtual online application, why is it specific to specific locations? Why isn't it open to immediately to everyone and to just give access immediately to that, because it's very important, valuable information. So that's one. And the other one is just a question about the boarding passes that we have on our, like, what are those basically? Thank you.
Thank you, Masa. Why don't you answer to the boarding pass question first? We'll come back to this other one.
The boarding pass, this is a one-way ticket simulation about the experience of Syrian refugees. And when you scan it, there is like, you kind of follow the campaign, half Syria, which is mean the half of population of Syria outside the country. And what's the situation, why they are, where there's like the biggest wave of migration in Syria happening. And on back, there's like also explanation about like what's the situation, what does mean the half of country. And also I forgot to screening the video of the white helmets, like it's usually the questions, it's why there is a lot of refugees in the countries and why they fleeing the country. So there's a one minute video about our work in Syria, about the bombardment of Assad regime and Syrian army and Russian army. And one of them, like the girl that we pulling them from under the rubble, and she was 16 years old and she was pregnant. So, and she was wounded from the bombardment. And we have now urgent situation. I'm sorry, I'm gonna take a time, but there's like an urgent situation. If we are NGOs workers and if we are human rights defenders, we shouldn't remain indifferent when there's genocide happening now in Syria. Idlib, a city in the north of Syria, which is including 4 million of people, under Assad attack, we just like last week, we lost 6 centers of the white helmets, one of them maternity health centers, and 25 of hospitals have been targeted by systemic way of Assad regime. 600 of people, civilians, have been killed by the bombardment and bombing civilians, including 126 of children. So if we're working in NGOs and the human rights defenders, we should not allow for many genocide that's repeating and there's the same history repeating every time. And I want to just like to screen the video, please.
We'll come to that at the end of the session.
Yeah.
But a call for action.
Yeah.
Clearly, when you're in a situation like that, it's hard and it's not possible to be completely impassive. Lulu, would you like to say something? And then...
I'll be very brief. This is one of the most inspirational plenary sessions that I have attended throughout Women Deliver. Chapeau bas, great job. Julian, the virtual youth spaces and the body drawing are amazing. You tackled 3 points, which is self-efficacy, which is psychosocial well-being, and which is knowledge of, adolescent sexual reproductive health services. And this is what we're trying to do in our SEEK trial. SEEK stands for self-efficacy, esteem, and knowledge. It's a community-based participatory trial that will target, hopefully, nothing without us, nothing about us without us. So it's among Syrian refugees. It's completely community-based participatory research. Hence, the refugees themselves will be shaping the intervention. Again, thank you for the comments on the health sector coordination and how, like when you started going, it can go. The attitudes of healthcare providers, that's spots on. Like, we really should work in parallel integration. So thanks a lot.
Thank you. Please introduce yourself. And then.
Thank you. My name is Ana Batista. I'm from Mozambique. I'm the Dreams coordinator in Mozambique. This is a very important topic for us also. Mozambique have been passing through very difficult situation. In 1 month, we have 2 cyclones, level 4. And so we as health providers, as have been said here, all the structure of the health system was destroyed. So we can count only on the girls. So Dreams is also an opportunity that to empower girls as ambassadors, not only as ambassadors, but as mentors. So in such situation, those girls can also play a very important role providing service to other girls in the community in such difficult situations. So it's something that I think it's very important to count on as a meaningful youth engagement also. Thank you.
Say a word about Dreams. I'm not sure everybody knows what Dreams is.
Well, Dreams is a PEPFAR supported program targeting adolescent girls and young women from 10 to 24 for HIV prevention, but it's an holistic intervention in the schools, in the community and health facilities, and also with very strong component of meaningful youth engagement. Thank you.
So, we want to leave this session with some hope, and one of the hopeful messages is coming from this huge PEPFAR-supported Dreams initiative. For the very first time, we're beginning to see declines in HIV infection in a number of sites. Although these sites are small, they're not national initiatives, but we always imagine that these are difficult to achieve. You can't reduce HIV in adolescent girls. We're beginning to see positive signs of that with Dreams. And it was wonderful to hear that in Mozambique, in this terrible cyclone that you had, that these girls were then a resource for other issues in the community. Julian, do you have response to that question that you posed?
Yeah, sure. Thank you. And thank you for the interest in the virtual safe space. We're really excited about it. And ideally, it will be accessible to girls everywhere. It's virtual. You can download an app one day. But we do really want to take the time to pilot the tool because we don't know yet exactly, what kind of information girls will feel comfortable accessing from a mobile device. We want to make sure that we've addressed all the safety concerns that might come with that. We know that a lot of times parents or siblings are monitoring girls' use of mobile phones, and so there are some safety concerns. So we're designing features that will address that so that girls can easily, close out of the app so that there's no browsing history, these kind of things. And we also want to make sure that the app is designed in a way that girls who might have lower literacy or girls who have different sort of needs for information can feel comfortable using the app. So that's why we're doing the piloting in only 2 countries. But hopefully after that, we can also use the feedback from girls to improve the app and make it more widespread and more available. So I'm happy to talk to you afterwards.
One of the many interesting things Zainab said is this false debate about, basic needs and responding to sexual and reproductive health needs. And I love the way she brought that together by saying, if you give a young woman and a young man. I don't want to leave young men out of this discussion. Information about their bodies, about sexuality, about sexual and reproductive health, contraception, emergency contraception, safe abortion care. It helps them take care of their lives and take care of, so it's not a luxury and it's not an optional add-on. Any thoughts about this that perhaps Trump could hear? Anyone else? Any comments? Any questions? Yes, please.
Thank you. My name is Nadine Kayne. I work with UNFPA in Gaziantep on the cross-border program. First of all, I cannot agree more on what you said with this constant targeting of health facilities and healthcare providers in Syria. We know it's targeted. We know it's not an accident. And although we talk about it, nothing is happening. So I don't know what to do anymore. I try to talk about it, but with very little success. My question is for Jasmine and maybe also for Amani. But Jasmine, you said that with the health providers, what they needed to in order to address adolescent SRH were competencies. But to what extent was it competencies and not shifting values? And if it is also related to values and beliefs, did you manage to do something about that?
A quick answer.
Okay. Actually, this competence, just think, as a person you are not out of your value. Even though you have a formal education, but still you have your own value that really shapes your way of doing things. So when I talk about the ASRH competent workforce, of course, it links with the values, behaviors, and attitudes of the healthcare providers, but also capability. For example, adolescent girls will never come to a midwife or health providers if she has itching in her reproductive organ or in private part. She will tell, I have itching in my hands. So what the midwives or service providers do, okay, how many days, what you ate, is it allergic, blah, 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 then give medicine, go, tata, bye-bye. She does not go beyond presenting the problem. She doesn't know how to link these itching or headache linking to SRH counseling and SRH information so that the girls first time at least to know that what kind of options she can have and where she can get service and creating kind of comfortable situation. And that is the responsiveness we are talking about, the health service providers and the clients. That is adolescent clients. It's not adult, and it's easy for married women, you know that. So that is the blocking things is existing there. And our team will work on that with the doctors and sociologists together and how to create a kind of local algebra or algebraic formula so that midwife or service provider can follow. If someone comes with pain in back, we still have to link with family planning because we target to address the unmet need of family planning. And we really need to be smart against fighting against the social bad norms that is really blocking the health service for adolescents. Yeah, thank you.
Thank you, Aklima. I can completely endorse that. You know, I worked as a clinician in Zambia for 10 years. Patients, generally, young men would generally come and say, I have a headache. And then halfway through the conversation, actually, doc, that was not the problem I came with. And so, you know, they're sussing you out. And if they don't feel comfortable, they walk away with chloroquine tablets for malaria, which they'll throw in the dustbin on the way out. So you're absolutely right. So how do you create that? And in this, you know, it's not as if you have the luxury to have a 45-minute appointment. Yeah. This is done in minutes. And how do you quickly give the sense that, yes, I'm willing to listen? A quick response. And then I want to end with Muzna's request. This is a session on humanitarian emergencies. So we'd like to see that little clip and see what the bombardment is. But first, you, Amani.
Yes. Exactly. For what Dr. Nadine has just mentioned, yes, well, it's not related to competency, actually. It's related to the norms, gender norms, social norms, and what we are trying to do through our program, Young Mothers Club, and maybe there is also a video of 2.5 minutes after Muzna's video showing how we are working with adolescents. We are working also with health providers on their social
gender norms, their attitudes. It's called social analysis and action approach that Care International has developed, and we are, as local councils and local NGOs are working to implement and pilot that. So we are utilizing like this participatory interactive dialogue with the adolescents, the community members, mothers-in-law, health providers to reach and to exactly ensure that the health facilities are truly responsiveness to adolescent SRH needs.
Thank you. Shall we?
نحن وقت اللي تزوجنا عيالنا كان عمرنا 13 سنة. نحن كنا فرحانين انه ايش بدنا نلبس هالبدلة، بدنا نلبس هالطرحة، رح نلف، رح نرقص، هيك كنا مفكرين. الزواج ما كنا مفكرين انه مسؤولية وهيك، يعني ما كنا كل هالشي مفكرينه. أنا ربا من معرة النعمان، عمري 18 سنة. أنا ما كنت بعرف إنه شو هو الزواج، شو هو المسؤولية، شو هو الأولاد. أنا كنت طفلة وقت اللي صار عندي ولد. وبعدين جيت حضرت وقت اللي سجلت بالمركز اسمي، وقالوا لي بعد فترة يعني بندعيكي لتحضري معنا الجلسة. كان هو في 8 جلسات لأمهات صغيرات، كل أسبوع جلسة ولمدة شهرين. جيت حضرت هون أول جلسة، طار عقلي، انجذبت كتير للموضوع، حكيت لصديقاتي شو عم بيصير معي، شو علمتنا الآنسة. كمان انبسطوا لأن ظروفهم ما بتسمح لهم يجوا يحضروا معنا.
أنا يمنى اليحيى، بشتغل مرشدة نفسية بمركز ريحانة.
So thank you very much for joining us for this session. We want to leave you with a hopeful message, but is it okay if we put this little clip of the bombing? They took it out. Okay, I'm sorry it's not there. So,
The cue was missed. You can play it now. It's the reality that we live in.
No, but it was literally taken out. Sorry. Yeah, it physically was edited out right in the middle of the session.
Can you play the video, please?
Is the first video still there?
Thank you.
Okay, sorry, I didn't understand.
I think this is, thank you very much. This is an apt ending to this session. It reminds us of the horrors of the situation in Syria, but it also reminds us something that Muzna, Julien, Amani, and others have said. Even in this situation, the needs of adolescent girls for sexual and reproductive health should not be set aside, should not be ignored. They're as important as the needs of the child who has been injured. It's a horrific situation in so many parts of the world. And can you join me in giving this smart, young, good, professional group of women for the great work that they're doing?
Thanks
I'd just
a lot.
like to leave you, I can see tears in some eyes, there are tears in my eyes. What Zainab said is something that I'd like you to think about as you go back, as you leave the room, that we have to stop this and we have to build back better. We have to build back better. Thank you very much, Zainab.
Thank you.
Thank you for all the great work you're doing.
Thank you.
Thank you all. Huh?
A natural disaster is something that we cannot really do anything about. We can only react. When something is happening by another human being, it's happening by choice. And it's, even if it's just keeping the conversation happening, it means that you are doing something. This started in 2011. This is still happening today as we are here now, and it's not stopping anytime soon. And it's so inspiring to see that even within that, the White Helmets are actually putting work into creating centers and places for adolescent girls and women to go and seek support, even if it's really difficult for them to access it. They're still creating the space for it to happen, and they're actually saving lives. And I have so much respect for everything that you do. So thank you.
Lots of love to you all. End of the session. Thank you very much for coming. Need a photograph of you. Come together. Come, Zainab. Join us for a photograph. Come on, you need to.